Okay, let's talk a bit about pathology of liver and cirrhosis now. Yeah. So talk to me about alcohol toxicity and chronic alcoholic liver disease.
All right, let's dive into liver pathology, focusing on alcohol toxicity and chronic alcoholic liver disease, keeping it short and simple. Alcohol toxicity hits the liver hard because the liver breaks down ethanol. Drinking too much too often overloads this process, causing damage. Here's the rundown on chronic alcoholic liver disease. Stages. It starts with fatty liver, steatosis, where fat builds up in liver cells from alcohol metabolism. This can reverse if you stop drinking. Next is alcoholic hepatitis, with inflammation, liver cell death, and symptoms like jaundice or belly pain. Finally, cirrhosis. Scar tissue replaces healthy liver, hardening it and wrecking function. How alcohol hurts. Ethanol turns into acetaldehyde, a toxic byproduct, via liver enzymes like ALDH. This messes with cell membranes, triggers inflammation, and produces free radicals that damage DNA and proteins. Over time, this scars the liver. Fibrosis. Cirrhosis features. In cirrhosis, the liver gets nodular, scarred, and shrunken. Blood flow stalls, portal hypertension, causing swollen veins, belly fluid, ascites, or brain issues, encephalopathy. It also raises liver cancer risk. Key signs: yellow skin, fatigue, easy bruising, or swollen legs. Blood tests show high liver enzymes, ALT, AST, or low platelets. Biopsy confirms scarring and fat. Risk factors: heavy drinking, more than 3-4 drinks daily for years. Genetics: some metabolize alcohol worse. Obesity and viral hepatitis like Hep C speed it up. Women are at higher risk due to less body water and slower alcohol breakdown. Stopping alcohol can halt progression but won't undo cirrhosis. Treatments manage symptoms like diuretics for ascites or meds for encephalopathy. Transplant's an option for end stage. Want more on cirrhosis complications or other liver diseases?
Okay, so we have steatosis, fatty change, and explain to me hepatitis and cirrhosis. And then I want to ask you about liver function tests like bilirubin and total protein and albumin.
All right, let's break down steatosis, hepatitis, and cirrhosis in chronic alcoholic liver disease. Then cover liver function tests like bilirubin, total protein, and albumin, keeping it simple and short. Steatosis, fatty change. Fat builds up in liver cells due to alcohol metabolism. Ethanol disrupts fat breakdown, causing greasy, swollen liver cells. It's reversible if you stop drinking, showing few symptoms, maybe mild fatigue. Hepatitis. Hepatitis is damaged by fatty and cirrhosis. Hepatitis is also encephalopathy. Steatosis is chronic hepatitis. Inflammation from alcohol toxicity kills liver cells. Acetaldehyde, alcohol's byproduct, triggers immune attacks, leading to jaundice, belly pain, fever, or nausea. It's a middle stage, not always reversible, and can progress to worse damage. Cirrhosis, end-stage scarring where healthy liver tissue turns into hard, nodular scar tissue. Blood flow gets blocked, portal hypertension, causing swelling, ascites, brain fog, encephalopathy, or bleeding veins. It's mostly irreversible and raises cancer risk. Liver function tests. These gauge liver health. Bilirubin, a yellow pigment from red blood cell breakdown. Normal is about 0.2, 1.2 grams per DL. And hepatitis or cirrhosis...
Okay, dude, don't forget, I want you maximum 2 sentences. You are talking too much. Okay, I'm going to be jumping back and forth with pathologies. Now I want to talk a bit about the urinary tract. We've talked a lot in the latest episodes about kidney disease, so let's talk about urinary tract obstruction reasons, maybe the causes. So calculi, stones, stricture, explain these words to us too.
Urinary tract obstruction blocks urine flow, caused by calculi, kidney stones, hard mineral deposits that lodge in ureters, or strictures, narrowed areas from scar tissue or injury. These lead to pain, infection, or kidney damage if untreated.
Okay. Interesting. And what are some hematological tests we can do with iron deficiency anemia, folate B12 deficiency, and clotting factors? Tell me about hemoglobin, MCV, INR.
For iron deficiency anemia, folate B12 deficiency, and clotting issues, key hemoglobin MCV, and microscopically low in iron, folate, B12 deficiencies, normal 12-16 grams DL, women, 13-18 men, MCV, mean corpuscular volume, low, -80, FEL and iron deficiency, high, -100, FEL and folate B12 deficiency, and INR, measures clotting time, prolonged -1.2 if clotting factors like zeagyne
Why
are
would
low.
we have mean cell volume low in iron deficiency anemia but high MCV in folate B12 deficiency? And what is INR anyway? Why would it be raised in clotting factors abnormalities?
Low MCV, mean corpuscular volume, in iron deficiency anemia happens because iron is needed to make hemoglobin. Without it, red blood cells are small and pale. High MCV, via 100 FEL, and folate or B12 deficiency occurs because these vitamins are crucial for DNA synthesis, so cells grow big but don't divide properly. INR, International Normalized Ratio, measures clotting time. It's raised via 1.2 in clotting factor abnormalities, like low factor ZA or liver disease, because blood takes longer to clot due to missing or defective proteins. Want more on specific tests or clotting pathways?
I don't get... Okay. Tell me about possible causes of iron deficiency anemia in patients with alcohol use disorder.
Iron deficiency anemia in patients with alcohol use disorder can stem from chronic gastrointestinal bleeding, e.g., gastritis, ulcers, or varices. Poor diet, low iron intake, and malabsorption. Alcohol damages gut lining, reducing iron uptake. Liver disease from alcohol can also impair iron storage and metabolism, worsening anemia. Want more on diagnosis or treatment?
Okay. And why do patients with alcohol liver disease have the tendency to bleed? And talk to us a bit about the pathogenesis of alcoholic steatosis.
Patients with alcoholic liver disease bleed easily because the liver, damaged by chronic alcohol, produces fewer clotting factors, like Ia, V, 7, and has low platelets from spleen enlargement, portal hypertension. Alcoholic steatosis develops when alcohol metabolism boosts NADH, pushing fats into liver cells, and acetaldehyde from ethanol damages mitochondria, impairing fat breakdown, causing greasy buildup. Want more on bleeding management or steatosis progression?
No, actually that's good. What are other causes of fatty liver? And what about non-alcoholic fatty liver? I've never heard of that one.
Fatty liver, or steatosis, comes from fat buildup in liver cells. Beyond alcohol, causes include obesity, diabetes, high triglycerides, rapid weight loss, and certain drugs like corticosteroids. Non-alcoholic fatty liver disease, NAFED, is fat accumulation without heavy alcohol use, often linked to metabolic syndrome. Think obesity, insulin resistance, high blood sugar, or high cholesterol. It ranges from simple steatosis to non-alcoholic steatohepatitis, NASH, which adds inflammation and can progress to cirrhosis. NAFED is increasingly common, especially in Western countries, affecting 20-30% of adults. Want more on NAFED risks or diagnosis?
Okay, explain to us this non-alcoholic fatty liver. I don't understand it. And So is alcoholic hepatitis like the first stage and then it becomes cirrhosis, or I'm completely confused?
Non-alcoholic fatty liver disease, NAFED, is when fat builds up in the liver without heavy alcohol use, often due to obesity, diabetes, or high cholesterol. Think of it as the liver getting greasy from metabolic issues like insulin resistance. It can stay mild, simple steatosis, or turn into non-alcoholic steatohepatitis, NASH, with inflammation that may lead to cirrhosis, though not always. Alcoholic hepatitis isn't always the first stage of alcoholic liver disease. The usual progression starts with fatty liver, steatosis, which can develop into alcoholic hepatitis, inflammation from alcohol toxicity, and then cirrhosis, scarring, if drinking continues, but you can skip stages or go straight to cirrhosis with heavy drinking. Want more on NAFED progression or how to tell these apart?
I see. Okay, and what are some complications associated with a liver biopsy? And talk to me about alcoholic cirrhosis, like irreversible.
Liver biopsy complications include bleeding from punctured vessels, pain at the site, infection, or rare organ injury, with serious issues in less than 1% of cases. Alcoholic cirrhosis is end-stage scarring from chronic alcohol damage, mostly irreversible, causing portal hypertension, ascites, encephalopathy, and higher liver cancer risk. Stopping drinking halts worsening but doesn't fully reverse scar tissue. Want more on biopsy risks or cirrhosis management?
Tell me about other causes of cirrhosis. Viral hepatitis, hemochromatosis.
Cirrhosis, end-stage liver scarring, has multiple causes beyond alcohol. Viral hepatitis B and C triggers chronic inflammation, damaging liver cells over years, leading to fibrosis and cirrhosis. Hemochromatosis, a genetic disorder, causes iron overload in the liver, promoting oxidative stress and scarring. Other causes include non-alcoholic fatty liver disease from obesity, diabetes, autoimmune hepatitis, immune system attacks liver, and biliary diseases like primary biliary cholangitis, blocked bile ducts. Want more on a specific cause or cirrhosis complications?
Yeah, can we talk about hereditary and secondary hemochromatosis, please?
Hereditary hemochromatosis is a genetic disorder, HFE gene mutations like C2A2Y, causing excessive iron absorption in the gut, leading to iron buildup in the liver, heart, and pancreas, which can trigger cirrhosis, heart failure, or diabetes. Secondary hemochromatosis results from non-genetic causes like repeated blood transfusions, chronic liver disease, or high dietary iron, overloading tissues with iron and causing similar organ damage. Want more on diagnosis or treatment options?
I want to ask you about portal hypertension now, and also I want to ask about complications of cirrhosis.
Portal hypertension happens when scar tissue and cirrhosis blocks blood flow through the liver, raising pressure in the portal vein. This leads to complications like varices, swollen veins in the esophagus or stomach that can bleed, ascites, belly fluid buildup, splenomegaly, enlarged spleen causing low platelets, and hepatic encephalopathy, brain dysfunction from toxin buildup. Other cirrhosis complications include liver cancer, kidney failure, hepatorenal syndrome, and infections like spontaneous bacterial peritonitis. Want more on managing these or specific complications?
Tell me about I don't really get this one you just said, actually, these complications.
All right, let's simplify the complications of cirrhosis and portal hypertension, breaking it down to make it clear. Cirrhosis scars the liver, and portal hypertension is the high blood pressure in the portal vein from that scarring blocking flow. Here are the key complications in plain words. Varices, swollen veins in the esophagus or stomach from high portal vein pressure. They can burst and cause severe bleeding, like vomiting blood. Ascites, fluid buildup in the belly, making it swollen due to high pressure and low liver protein production. It can get infected, causing pain and fever. Splenomegaly, the spleen gets big because of backed up blood flow, trapping platelets and lowering blood clotting ability, so you bruise easily. Hepatic encephalopathy. Toxins the liver can't clear reach the brain, causing confusion, memory issues, or even coma in bad cases. Liver cancer. Cirrhosis raises the risk of hepatocellular carcinoma, a liver tumor that can cause weight loss or jaundice. Kidney failure. Hepatorenal syndrome. Poor liver function stresses kidneys, leading to fluid retention and reduced urine output. Infections, like spontaneous bacterial peritonitis, where ascites gets infected, causing fever and belly pain. These happen because the scarred liver can't filter blood or make proteins well, and high portal pressure messes with nearby organs. Want me to focus on one of these, like how to spot or treat them?
Wow. Guys, so much information. My brain is fucking swimming in information. Okay. So what kind of epithelium lines the bladder and why? Let's go a bit back, talk a bit about urinary tract pathology, and then we'll finish with pharmacokinetics. And tell us a bit about cystitis symptoms too.
All right, let's tackle this, diving back into urinary tract pathology, comparing bladder-like structures, covering cystitis symptoms, and ending with urokinetics, keeping it concise. Bladder comparison. The bladder, a muscular sac storing urine, is similar to the gallbladder and renal pelvis. All are hollow, stretchy organs that hold fluids, urine, bile, or filtered urine, before release, lined with transitional epithelium to handle stretching and chemical stress. Unlike the gallbladder, the bladder and renal pelvis are part of the urinary system, sharing infection risks like bacteria spreading from the urethra or ureters. Urinary tract pathology. Common issues include infections like cystitis, obstructions, kidney stones or strictures, and cancers, bladder or ureteral. Obstructions cause urine backup, leading to pain, hydronephrosis, kidney swelling, or infection. Chronic irritation from stones or catheters raises cancer risk. Cystitis symptoms. Cystitis or bladder inflammation, usually from bacterial infection, causes frequent, urgent urination, burning or pain when peeing, cloudy or bloody urine, and lower belly discomfort. Severe cases may include fever or back pain if the infection spreads to kidneys. Urokinetics.
Okay, that's all good. Let's talk a bit about prostatic cancer now and prostate needle core biopsies.
Prostate cancer is a malignant tumor in the prostate gland, often adenococcinal, with common xanococcinal, driven by age, genetics, or hormonal factors. Needle core biopsies, guided by ultrasound, take small tissue samples from the prostate to diagnose cancer, grading it via Gleason score for severity. One more on risk factors or biopsy complications?
Tell me about prostatic chips from transurethral resection of prostate.
Prostatic chips are tissue fragments removed during transurethral resection of the prostate, TURP, a surgery to relieve urinary blockage from benign prostatic hyperplasia, or, less often, prostate cancer. These chips are examined under a microscope to check for cancer, adenococcinal, Gleason grade, or other abnormalities, guiding treatment decisions. Want more on TURP risks?
Let's go and finish pharmacokinetics now. So, drug clearance. Explain that.
Drug clearance is the rate at which the body removes a drug from the bloodstream, typically measured as volume of plasma cleared per unit time, e.g., ml per minute. It's driven by liver metabolism via enzymes like cytochrome P450.
And what are some, keep it really short, tell me some reasons of low or high drug clearance now.
Low drug clearance, liver or kidney dysfunction, genetic slow metabolizers, enzyme inhibitors. High drug clearance, fast metabolizers, enzyme inducers, increased organ function. Want specifics on a drug or condition?
That's so good. Introduce us to the idea of loading dose now. and why we have different graphs for loading dose PO versus IV.
A loading dose is a high initial drug dose given to quickly reach therapeutic blood levels, used when rapid effect is needed. IV loading doses give a sharp, instant peak on a concentration time graph. Y-axis, drug concentration, x-axis, time, since the drug hits the bloodstream directly, while oral, PO doses, show a slower, rounded peak due to absorption delays in the gut. Want more on calculating loading doses or graph details?
Explain. I still don't understand though why the loading dose PO goes up and down versus the IV that goes.
The IV loading dose shoots drugs straight into the bloodstream, spiking concentration instantly on a graph. Y-axis, drug concentration, x-axis, time, then dropping as it's cleared. The PO loading dose takes longer, rising slowly as the gut absorbs it, peaking later with a gentler curve, then falling, due to
But why
slower
does it
absorption.
go up and down, up and down, up and down, whereas the IV goes straight?
The PO loading dose doesn't really go up and down in
Well,
one
that's
dose.
what I'm seeing here. It's going like sine X.
Okay, I hear you about the PO loading dose graph looking like a sine wave, up and down like sine X. That's not typical for a single dose, so let's clear this up simply. Assuming you're describing a concentration time graph, y-axis, drug concentration, x-axis, time, for oral, PO versus IV administration. A single PO loading dose doesn't oscillate like a sine wave. Instead, it rises slowly as the drug is absorbed from the gut, hits a peak, usually within 1-2 hours, depending on the drug, and then falls smoothly.
What
as
does
the
PO mean anyway?
PO means per os, Latin for by mouth, referring to oral administration of a drug, like swallowing a pill. It contrasts with IV, intravenous, where the drug is injected directly into the bloodstream. Want more on how PO dosing affects pharmacokinetics?
And what about dosing of drugs? What's the relationship between half-life and volume of distribution and clearance?
A drug's dosing is guided by its half-life, volume of distribution, VD, and clearance, which are linked. Half-life, time for drug concentration to drop by half, depends on clearance, rate of drug removal from blood, ml per minute, and VD, how widely the drug spreads in the body, L. The formula is half-life equals 0.693 times VD.
So why is
divided
it
by
directly proportional to volume of distribution? So the more it's distributed, the bigger the half-life, and the less the clearance, the more the half-life. Okay, that makes sense.
Exactly. You got it. The half-life of a drug is proportional to the volume of distribution, VD, because a larger VD means the drug spreads more widely in the body, like into tissues, so it takes longer to clear, increasing the half-life. Lower clearance, slower removal by liver or kidneys also extends half-life, since the drug lingers longer.
I get
It's all
clearance, but to be honest, I don't get the volume distribution, why it extends half-life.
Volume of distribution, VD, is how much a drug spreads into body tissues versus staying in the blood. A high VD means the drug moves out of the bloodstream into organs, fat, or muscles, so less is available in the blood for the liver or kidneys to clear at once.
Okay.
Slowing clear.
Thank you guys for watching.